right, you are fully dilated. It is time to push.
I'm actually not feeling the urge yet. Can I wait?
Want to delay pushing? Because that does have some risks, like infection and bleeding.
I'm aware of that small risk with an epidural, but I'd like to protect my pelvic floor, and laboring down can do that.
1 hour later.
You are pushing so good. Doctor's on their way, so let's get ready for him and just pop onto your back for me.
No, I'm comfortable here. Gravity's on my side, and my sacrum can move 4 times more.
I've never seen this doctor deliver anybody in any other position.
I'm sorry to hear that. All 4s feels natural and controlled for me with my contractions.
Now, this video was done by a labor and delivery nurse and a fitness trainer who does the Bell method. I'm going to go through some key points in that video because pushing and when to push and how to push is such a hot topic on social media that everybody's got something to say about it. And so do I. Okay, point number 1. Is it necessary to immediately start pushing when someone's completely dilated? The answer is no. The cervix being completely dilated along with assessment of the station of the fetal head in the pelvis is important. If the fetal head is higher up in the pelvis, you may want to take some time for that fetal head to come down before starting pushing. On the other hand, there are some people who are completely dilated and the fetus is high in the pelvis or higher, and they got to push and they want to push and they push and the baby comes out, especially those people who have delivered babies before. There's no one right answer. Everybody's different. That's why it's important for someone who knows how to assess fetal station and cervical dilation to help make that decision with the patient. There's a lot of clinical nuance involved. A lot. Next point, waiting to push until you feel the urge. I absolutely agree with that. Not feeling the urge or not knowing where to push because you feel pressure is not ideal because the patient may just push through their upper body, through their mouth, through their face. So they need to know where to direct their energy. Next, let's talk about delayed pushing. Now, delayed pushing is also known as laboring down or passive descent. And that's that period of time when the cervix is completely dilated and there's no pushing, and instead the uterus continues to contract, and the forces of the uterine contractions can cause the fetal head to descend in the pelvis and do its rotational maneuvers necessary to go ahead and effect delivery. The ability to labor down is also dependent on the status of the fetal heart tracing. I'm a big fan of fetal heart tracings, especially during the second stage of labor, because it's very common for fetuses to start having fetal heart rate decelerations once they're completely dilated and descending into the pelvis. Again, a lot of clinical nuance. That's why it's important for someone who is an expert in the field and trained in the field to help make those decisions with the patient. Now, I'm going to steal some content from my good friend, Dr. Daoud, about the benefits of laboring down. Laboring down gives a patient a little bit of a respite or rest period before they start to actively push. They can help them to conserve some energy. During that period of time, again, the baby is descending and rotating into the necessary position in order to be delivered. So that could be a key time for the patient. Now, there have been 2 meta-analyses of randomized control trials looking at delayed pushing versus immediate pushing. And both studies showed that delaying pushing for 1 to 2 hours, which I would never do, by the way, I do 30, maybe 45 minutes tops, but delaying pushing for 1 to 2 hours extended the total duration of the second stage by a mean of approximately 1 hour and was associated with approximately 20 minutes less of active maternal pushing efforts. 20 minutes. Both studies show that there's no difference in the spontaneous delivery rate when it comes to laboring down versus immediate pushing, and there are risks. Another study showed that delaying pushing by 60 minutes or more was associated with modest increases in cesarean delivery rates and operative vaginal delivery and postpartum hemorrhage with transfusion. And a 2018 randomized controlled trial had to be stopped early because the subjects in the laboring down group, when compared to those in the immediate pushing group, had significantly higher rates of postpartum hemorrhage, infection or chorioamnionitis, and neonatal acidemia. Neonatal acidemia at birth is not a good thing for the neonatal brain. Next, does laboring down protect the pelvic floor? We don't know. Some studies show that there's no difference on the pelvic floor months after delivery when you compare delayed pushing versus immediate pushing or directed pushing. It seems, according to the data, that how frequently the patient pushes along with how long they push has more of an effect on the pelvic floor. That means how long they push per contraction and also how long the active pushing part of the second stage of labor is. Finally, the good old pushing on your back versus pushing in some other position. It's important to understand that there is no study that's going to answer that question. Which position is best? Not going to happen. There are too many confounding factors, variables at play. So currently there's no evidence that shows that pushing in one position is better than pushing in the other. So all these things y'all hear on social media about push this way, push that way, open your pelvis, do this, none of it has been proven, y'all. At the end of the day, you push in the position that you're comfortable with, period. And what I find is a lot of those people who are telling you that we are making people push on their back or to absolutely refuse to do that are those who have never pushed with a patient. Never. Never checked a cervix, never assessed fetal station, never repaired the perineum. Those are the ones that are the loudest.